I disagree. I think what we have to keep in mind in stage 3 disease, that just by surgery, we are curing roughly one third of the patients. I mean, in multiple trials, including the EOTC trial, we have seen after 5 years, roughly one third of the patient would have not needed any adjuvant treatment.
2/3. Actually, it's 54% in the IPI trial who are cured at 5-year mark, and it's 65% who are without relapse, at 65% who are without relapse at 5 years.
And one has to keep in mind that there is also, if you look at the kinetics of relapses, for patients who are in the placebo arm, this is true for the old EP trial as well as for the Combi-ID, most of the relapses do occur within the first 18-20 months. And that you have a stabilization of the curve, even if the placebo-treated patient population, which stabilizes after months 24, 30. And that's what you see with all the other curves as well. And that's the reason why I don't believe that there will be a crossing of the curves with the checkpoint inhibitors, because most of the relapses do occur within the first 30 months. And after that, you have the stabilization of the curve. And that's what was shown with targeted therapy, with a calculation of a cure rate. And that's what you will be able to do also with the checkpoint inhibitors. I believe the curves will stay very close together, and it will be hard to discriminate if you compare the different trials. I mean, we can have discussion on different patient selection, which were included, and all of that. But I think that's academic. For the patient, it's clear, it's very close, and the kinetics, as Lex described, that with checkpoint inhibition, you have a certain chance to have a relapse early because the tumor is not controlled within the treatment period. For the targeted therapy, you have the risk after stopping the treatment that some patients start to regrow. At the end, for this 60-70% of the patients, probably they have a good chance to be cured.
So still, I must remind you of advanced disease. 3-year survival rates with Nivo-IPI are 68% for BRAF mutant patients. For BRAF mutant patients, the 3-year survival rate for a BRAF-MEK combo is 45%. I'm sorry, that is a huge difference. And I put a bottle of Dom Pérignon on it that they will cross also in the adjuvant setting. I'm totally convinced of that because immunotherapy is simply superior.
Yes, but you have all these contingent of patients who will not relapse. So it's not like metastatic disease where they will all relapse.
You will see the curves will cross at 2.5 years. I promise you the curves will cross.
Well, we wait and see. You
need more? I promise you.
So I think what we do now is, I think from the discussion, it's obvious that there's some really good data out there.
So that's why it's not easy when you explain it to the patient.
Exactly. Yeah. So I'm going to go back to you, Caroline. You mentioned earlier patient selection. So in my clinic, when I talk about this, I do exactly what you do, which is discuss the different options. And I kind of tell them that simplistically, it's chronic toxicity that you can quickly turn off when you stop the oral drugs for BRAF-MEK. With the immunotherapy, mostly you will not have a toxicity, but if you do, it could be longer lasting. Is that what you do? And are there any patient factors specifically that drive you to advise a patient one way or the other?
Yes, of course, if you have an active autoimmune disease.
Yes. Say no autoimmune disease, just a patient, any other factors?
A transplant organ.
Okay, yeah.
No, things like that. Or a patient who is not going to be reliable, who is not going to call me if he has a problem.
So then you prefer the oral drugs for that patient?
Yes.
Okay. How do you then ensure compliance of taking the drugs at home?
So we see them every month, and we call them easily if we don't hear from them, and at least every month.
Yeah.
I also try, honestly, to tell every patient, and it's difficult in this setting of adjuvant where patients are not so sick sometimes, but I always oblige myself to tell them that there are very serious adverse events that can occur with anti-PD-1, even fatal. And it's very difficult to say that because it frightens them a lot, but I think we have to tell them it's extremely rare, but it can happen. Because I think if you don't tell them, I mean, they can reproach that.
Yes.
Why didn't you tell me? I read you can give
Yeah,
myocarditis.
it's important to discuss with the patient every aspect.
I really think we need to do that, and sometimes it's make the atmosphere a little bit cold,
Yeah,
but
yeah.
we have to tell that.